Smoking Cessation in Teenagers, an evaluation of the success of the American Lung Association's Not on Tobacco program. Tobacco is the leading cause of death in the United States as of the year 2000, contributing to cancer and cardiovascular disease deaths, among others. The cost of medical care for a smoker versus a non-smoker is $75,000 greater. Not only that, but on average, smokers can expect to live 20 years less than non-smokers. Most adults smoking today report that they began as a teenager. The Not on Tobacco (NOT) program was developed by the West Virginia State University Centers for Public Health Research and Training, West Virginia State Health and Education Departments, the Coalition for a Tobacco-Free West Virginia, and the American Lung Association. This program was developed to stop smoking early on in the life of teens so it would not become a lifelong habit. The NOT program was developed with youth in mind, ranging from 14 to 17 years of age. The NOT program consists of 10 weeks of smoking cessation sessions lasting 50 minutes each. These sessions are led by an individual who attended an American Lung Association NOT training program. These individuals would lead gender-segregated small groups not to exceed 12 teens in a relaxed setting. There were a number of skills the program sought to develop in order to achieve smoking cessation, including stress management. Wide dissemination of the program and adaptability of the program to each region is essential for its effectiveness. While the NOT program as originally developed is better suited for urban and suburban environments, tailoring the program for rural environments benefits teens in those areas that face different struggles. The NOT program is an effective smoking cessation program for teens living in rural areas because it is cost-effective, teaches coping strategies, and is relatable to teens. There are a number of determinants of health that come into play. Social determinants are a very large factor. Teens are influenced by their peers more than their family. Teens that have friends and significant others that smoke are more likely to smoke themselves. However, teens that have siblings and family members that smoke are also more likely to smoke. Social media and celebrities that are shown smoking also have an influence on teens, and some cite these pictures or movies with celebrity smoking as the reason they tried. The NOT program teaches teens skills on managing relationships with people in their lives that smoke, as well as how to deal with the stress associated with the pressure these individuals may place on them. One economic determinant of health is the price of cigarettes. Teens are more likely to only have a minimum wage job, if they have a job at all. The high cost of cigarettes is a deterrent in some areas of the country. However, areas where cigarettes are sold at lower prices, teens are able to afford them. Another determinant is rural teens living in areas of tobacco and cigarette manufacturing have families that depend on cigarette companies for their jobs and livelihood. Cigarettes and tobacco are normalized and needed to sell in these areas. The NOT program is a cost-effective solution to provide teens with skills needed to stop smoking and stay smoke-free. With the eradication of many deadly diseases and the advent of antibiotics, preventable causes of death and chronic diseases are at the forefront of public health concerns. With the rising cost of health care and the increased lifespan, smokers are costing more money to treat and living shorter lives than the general population. The NOT program is a cost-effective and successful program to reduce the number of teens smoking in rural areas. Horn, Keskler, and Modi explain that by using a combination of psychology for learning and learning by experience, the NOT program is a comprehensive smoking cessation program for youth. Its effectiveness comes from not just teaching and telling someone how to have healthy habits, but by showing, practicing, and implementing those habits through role-playing, journaling, or active meditation. The NOT program was developed in West Virginia in 1998 by the West Virginia State University Centers for Public Health Research and Training, a division of the CDC's Prevention Research Center, and researchers from the state. After successful implementation, the American Lung Association adopted the NOT program as a national youth smoking cessation model. Soon after, it was endorsed and recognized by the Substance Abuse and Mental Health Services Administration as an evidence-based model program, the National Cancer Institute as a research-tested intervention program, and the Office of Juvenile Justice and Delinquency as a prevention model program. Primary stakeholders in a West Virginia NOT program dissemination model were identified as the Community Partnership Board of the West Virginia Prevention Research Center, the American Lung Association in West Virginia, the West Virginia Department of Education, and the West Virginia Division of Tobacco Prevention. The counterparts of these divisions in various states implementing NOT would be the stakeholders for those states. Each of the stakeholders played key roles in the disseminating the program throughout the state. The Education Department supplied locations and facilitators, schools as program settings, and school employees to serve as facilitators. The ALA of West Virginia provides training to NOT facilitators and program materials. The Division of Tobacco Prevention in West Virginia and the 4-H clubs locally in the regions served as contact points from the coordinators and facilitators within the schools to the ALA of West Virginia and state contacts. The West Virginia State University Centers for Public Health Research and Training provide statistical management, research, and publication of the results of the programs. When developing and implementing the NOT program, school children's school time, 50 minutes for 10 weeks, and non-classroom settings were utilized. A cost-effectiveness analysis of the NOT program in terms of actual cost to implement and discounted life years saved for individuals is not only cost-effective, a good value, but it is also more cost-effective than adult smoking cessation programs. To put the cost of implementing the NOT program in perspective, it was determined that one student abstaining from purchasing cigarettes for a year would be able to pay for the program with the money saved. Although this is not a feasible or realistic source of funding, it is incentive for investors to see the money saved on cigarettes could be put back into the economy by teens in other ways. Program funding for NOT comes from a variety of sources. A large source of funding is from primary stakeholders. Many of the studies to evaluate the effectiveness of NOT as a teen smoking cessation program were funded by a branch of the CDC and the West Virginia State University Centers for Public Health Research and Training. Program funding for NOT, as well as any other program implemented in school, is also given to schools by individuals in charge of state policy and school health policy. Program funding also has potential to come from other external sources. One such source of program funding for NOT is the Tobacco Industry's Master Settlement Agreement. This settlement mandates that tobacco manufacturers fund youth smoking cessation programs. Additionally, states allocate money annually for public health programs. The NOT program falls into the category of public health and would be eligible for state-allocated funding. Allocating some of this money to teen cessation programs and not just adult cessation programs may be more cost-effective for the state and its citizens. There are a number of ethical concerns when it comes to adolescents participating in smoking cessation program and research on the effectiveness of a smoking cessation program. The first issue relates to informed consent. Informed consent indicates that the participant knows what is being asked of them and why it is being asked. Minors need to be assessed in terms of maturity and level of understanding of the research before they are able to participate. Informed consent from an adolescent also includes informed consent of their parent or guardian to participate in the research. This causes a potential problem as it could affect the recruitment rate of the participants. In this instance, teens that smoke but their guardian is unaware of this fact would be less likely to participate in research or a cessation program where their guardian is required to give them permission. A second ethical concern for research participation of an adolescent is to assess the risk-benefit profile. The researchers and IRB need to assess if the research is capable of harming the adolescent, what information will be gained if the research is approved, will the participants benefit from the research, will there be no direct benefits to the participants, and/or is there generalizable information to the adolescent population to be gained from the research. Another ethical concern is that of confidentiality. In the case of smoking cessation program, there may be issues with confidentiality of the adolescent if the parent, guardian, or school administration does not know they smoke. The adolescent may be reluctant to divulge this information to these parties for fear of repercussions. Confidentiality also comes into play if the research of the program or the program gathers information from the participant on other family members and whether data is gathered with or without the consent of other family members. Teens are also driven by peer relations at this time in their life. This creates another concern of confidentiality if the teen wants to include their friends in the cessation program. This could create problems with maintaining confidentiality for all participants if participants involve their friends outside of the study. Data often collected on teens involved in smoking cessation programs involves other illegal behaviors, such as recreational drugs, alcohol, and sex, and confidentiality must be maintained. Yet another ethical concern is compensating adolescents or their guardians for a smoking cessation program. Researchers and program managers need to make sure that compensation is not the focus of their recruitment strategy for the research or program. Monetary compensation for teens in a smoking cessation program could cause potential ethical concern if there are teens who are involved in illegal drugs and alcohol because the money could directly fund these other habits. Other compensation is preferable in this case of these programs, like gift cards and concert tickets. With teen smoking cessation programs, there are a multitude of ethical concerns that are in play and must be addressed before the program can be evaluated. Opponent to youth smoking cessation programs is the tobacco industry. Although the tobacco industry has created youth smoking cessation programs, none of them were found to be effective. The cessation programs place the blame of teenage smoking on lack of role models, peer pressure, and following the law. Their programs failed to address the addictive nature of nicotine, the adverse health effects of smoking or secondhand smoke, and how tobacco marketing promoted smoking. The tobacco industry has two ways to increase revenue: increase the number of new smokers and get current smokers to switch to their brand. Although the tobacco companies argued that their primary revenue was having existing smokers switch brands, studies show that marketing to adolescents increases the number of new smokers the tobacco companies get addicted. Tobacco companies rely on these new smokers, especially young smokers, as a way to increase revenue. As it has been previously stated, tobacco-related death is the leading cause of death in the United States as of the year 2000. What makes this unique, unlike inherited diseases or accidents, tobacco-associated death and complications are preventable. The cost of caring for a smoker in the healthcare world is $75,000 greater than a non-smoker, and the smoker has a lifespan 20 years less than the average non-smoker. With the rising cost of medical care and a well-established complications, morbidity, and mortality related to smoking, smoking cessation is a priority in the field of public health. Because most adult smokers report initiating smoking in their youth, finding an effective youth smoking cessation program is essential. By stopping smoking before it turns into a lifelong habit and addiction, the ill effects of smoking can be reduced or eliminated for the youth and their future. This would ultimately cut down on the long-term cost of care of these individuals as well as extend their lifespan.